Hi everybody. So now we're going to talk about oral cavity problems. And it seems like kind of a boring subject, but I just want you to remind you that we do a lot of different things with our mouths. Kissing with our mouths, we drink, we eat, talk, breathing, all of those different things we do with our mouth. So we are subjected in our mouth to a lot of different substances and a lot of different bacteria and viruses. So some of these things that we're going to talk about are from viruses and foreign substances, chemicals, that kind of thing. So these chapters that we're talking about right now are all because we're talking about digestion of food, the digestive system. So as you recall, the digestion of food begins in the mouth. So we've already talked about enzymes in our saliva assist with breakdown of carbohydrates. If you remember that, salivary amylase. So here I'm showing the pharynx, or the throat, that's between the mouth and the GI tract, and it has a role in both digestion and gas exchange, like I said. So air is breathed in through the nose and passes down the nasopharynx into the oropharynx and down into the trachea. So when there's an issue with this area, you can see problems arise with both gas exchange and with digestion. So we're going to talk about stomatitis and oral cancer specifically in this particular section. So stomatitis, stoma is just another way of saying an opening. So our mouth is an opening, so stomatitis is inflammation of the oral cavity. So ulcers appear as inflammation and erosion of the protective lining of our mouth. So sores can cause discomfort and put a patient at risk for bleeding and infection. So we can have patients with a single lesion or multiple different lesions, and some of those ulcerations are called aphthous ulcerations or canker sores. So if someone has just mild redness, maybe just barely a little tiny sore, we can use topical treatments. But if somebody has extensive stomatitis, it can be really painful. So we would maybe resort to even giving people opioids and giving them antifungals. We'll talk about antifungals a little bit later. So these sores can be very, very uncomfortable. So any interventions that we do for stomatitis are targeted toward promoting health and reducing the risk for infection by carefully doing oral hygiene and selecting food for the patient, or helping the patient select food that is comfortable to them. So Candida or yeast is a common opportunistic infection. We have normal flora, as you know, through our whole GI tract. Our mouth has its own type of normal flora, but an opportunistic infection is when that normal flora is destroyed, maybe by antibiotics or steroids, radiation, and so that will allow that fungus to be overgrown. So stomatitis is classified based on the cause. It's either primary or secondary. So primary usually means in any kind of thing we have, primary just kind of crops up. So we can have aphthous stomatitis, which are again just the canker sores herpes simplex, stomatitis, or we can also have traumatic ulcers, like people when they bite their lip and it might turn into an infection. Secondary infections, again, result from opportunistic viruses or fungus, bacteria, in people who are many times immunocompromised, like people who have cancer, people who have AIDS. People can also get secondary infections because of medications like chemotherapy. And the fungal infections that build up are called candidiasis or thrush, moniliasis. Again, it's very, very painful. People cannot even drink water. Recurrent aphthous ulcers are more prevalent in females than in males. So stomatitis can occur from allergies, vitamin deficiencies, and irritants like alcohol and tobacco. So alcohol and tobacco are not friendly to our mouth at all. Other things that we can get because they trigger allergic responses causing aphthous ulcers are coffee, cheese, nuts, citrus fruits, and even gluten. Some people think that there is a genetic linkage. Evidence suggests that the immune system in some patients with frequent stomatitis is maybe even partially related to a genetic predisposition. So there are a lot of things that we'll talk about throughout all of these chapters. There's usually some little excerpt in every one of these chapters about people being genetically prone or predisposed to a lot of these disorders we'll talk about this entire semester. So how do we manage stomatitis? Again, I just want to reiterate that it's very painful. Good oral health helps to discourage stomatitis. However, we can't always completely prevent stomatitis. You have to assess and take a good history. So what's the person's nutritional status? Do they have infections somewhere else? Are they taking antibiotics? Are they taking over-the-counter drugs? Have they had trauma to their mouth? Are they under stress? A lot of people who are under stress tend to get blisters and sores, like they call them, quote-unquote, stomach sores. Oh, and what are the people's oral hygiene habits? Do they have good? Do they brush their teeth? Do they floss, etc.? If people are having difficulty swallowing, there may be lesions that extend beyond their mouth. So people might need swallow studies or EGDs, if you remember what that is, esophagogastroduodenoscopies, to see take a little camera and see what's down there. So if you look at the pictures that are on here, there is in the top right is a quote-unquote fever blister. And then if you look at the picture that I have there of the thrush, it looks like, you could like peel that off of there. And you actually, if you could peel it, it could be knocked off of there easily. And what you're going to find under there is very red, meaty, painful tissue under there. So that thrush there is kind of severe. So we'd probably need to be very careful, number one, using that tongue blade that person is using. But we need to use a pen light, we need to wear gloves, and really look down in there and see how far down that goes. We see how far down that goes as far as we can see. Sometimes it extends well beyond the mouth and pharynx and goes way into their esophagus. So that's where those EGDs come in handy. What you need to look for here also, looking with that tongue blade, is that when some of these stomatitis are severe, the throat gets very edematous, and there's a potential to obstruct the person's airway. So here's a piece out of your book on page 1077, chart 53-2, best practices for a patient, care of the patient with problems of the oral cavity. So this is from your book, the 9th edition. So again, what interventions can we use if somebody has lesions in their mouth that look like that? We want to use a soft bristled toothbrush, foam swabs, the ones like they have in the hospital, like you can dip them in water and, moisten their mouth. We want to use toothpaste that is free from sodium lauryl sulfate because it can burn. We want to rinse the mouth every 2 to 3 hours and avoid commercial mouthwashes, again, because most of them have alcohol in them, or they used to at least, and alcohol burns those areas. Drug therapy we can use, antimicrobials, antibiotics, antivirals, and again, if somebody has thrush like that, we're going to be using some antifungals. If lesions are from herpes simplex virus, there are antivirals such as acyclovir or Zovirax, especially for immunocompromised patients. Nystatin suspensions, swish and swallow. Nystatin is a yellowish kind of substance, and again, it's antifungal. So a person just swishes and swallows, especially if the doctor feels like the candida or manilial infection is going down into their esophagus, because that will help take care of that. Sometimes they do a nystatin swish and spit. So there are other things we can use, triamcinolone, in a benzocaine, which is kind of an, it'll help numb it. And something might also have steroids in it, some dexamethasone. And again, they would swish and spit those. So what kind of dietary changes? If you look on page 1078 in your book, they talk about dietary changes. And one of the things we want to promote is cool liquids. Hard, spicy, salty, acidic foods or fluids can be really irritating. Like I said, if you would be able to break off some of that thrush, there would be just raw exposed area in their mouth and tongue and on their palate. So that would be extremely painful. It's already painful to them to just have water in their mouth. High proteins and vitamin C promote healing. So you could include things like bananas, scrambled eggs, custards, puddings, ice cream. And all those tend to be milk-based products, so you wouldn't want to use those, of course, if somebody is lactose intolerant. Over-the-counter preparations can also be used. We use like Oragel for babies. That can be used as some kind of Orabase or Anbesol. Campho-phenique is also something that's over-the-counter that can be used as kind of a numbing agent or a soothing agent. There's a viscous lidocaine, which is just kind of like a lidocaine jelly that they can put in their mouth to gargle, kind of, or as a mouthwash. And there's also something that's a combination of medications that's called magic mouthwash. And we have lidocaine, which is an analgesic numbing agent. So the magic mouthwash contains that lidocaine. It has Benadryl in it, which, if you recall, that is an antihistamine. It has Maalox and Carafate and steroids to help with oral pain. Many times they use magic mouthwash for people who are immunocompromised and they have thrush because of cancer treatments. So, why does this stuff have Maalox in it or Carafate? Well, both of those substances, they're both medications that tend to adhere or stick to the oral cavity. So when you have lidocaine mixed with those and the steroids mixed with the Maalox or Carafate, that helps those other medications stick to the tongue and help like numb the medicine or numb the tongue. So I'm going to go back here. So on this particular slide, just make sure that you know foods high in protein and vitamin C. And the cool or cold liquids that can be soothing. You should have learned, like probably in fundamentals, that foods high in protein and vitamin C help heal. Like anytime, like after surgery, and in this case, as far as healing the mouth. Okay, so other oral cavity disorders. Oral tumors. So premalignant lesions. One is called leukoplakia. So I want you to look at this. And then I'm going to go back, if I can, to the, just kind of look at how this covers the oral mucous membrane. It's white and it's thick, but it's very firmly attached, and it doesn't look like you could scrape that off of there. Whereas if you go to this one and you look here at this thrush, it looks like you could definitely knock some of that off of there. And again, under there is that red beefy, would be a red beefy exposed area that would be very painful. So when we go back to the, sorry, I went too far there. We go back to this one, leukoplakia. Again, this is often confused with thrush or the candidiasis. So this slowly develops in the oral mucous membrane. It's thick, white, firmly attached patches, and they cannot be scraped off. Oral hairy leukoplakia is found in patients with AIDS and indicates progression. So people with human immunodeficiency virus who develop this indicate that they have actually progressed to the full-blown disease of AIDS. And this is associated with the Epstein-Barr virus. So here's just a comparison of leukoplakia to oral candidiasis or thrush. So with the leukoplakia, again, it's flat white lesion that cannot be brushed from the oral mucosa. It has a malignant, it's potentially malignant or can develop into a malignancy, so a biopsy is warranted if this is seen. Whereas on the other hand, oral candidiasis is a white plaque that easily brushes off with underlying red tissue underneath. And so we treat that again with antifungals like a nystatin swish and swallow or something like that, or swish and spit. So here's a example of erythroplakia. So this one is red and velvety, so erythroplakia. And again, this is on a lesion of the oral mucosa. This is another precancerous condition, and it should be biopsied. It's most common on the floor of the mouth, tongue, palate, and mandibular mucosa. So this one is hard to tell, like, what is really wrong with this person. So are they just having some kind of a inflammatory reaction to something, or an immune response? So it's kind of hard to tell. Squamous cell carcinoma. So if you can see here, I don't know how someone could not tell that that was in their mouth, but some people are just afraid to go to the doctor, and rightfully so, because sometimes people don't want to know what's wrong with them. But this is definitely a squamous cell carcinoma, and more than 90% of oral cancers are squamous cell carcinoma. So they start on the surface of the epithelium, and over many years, they have changes like this. The cells begin to vary in shape and size, and lesions can be large before they have symptoms. So that erythroplasia that you just saw, I'll go back to that so you can see it again, is the mucosal erythroplasia is the earliest sign of oral cancer. So there's that. And then here's the squamous cell carcinoma. So the people who are most prone, so the biggest risk factors here are smoking and drinking. Lesions that don't heal within 2 weeks, or people that have a lump in their cheek, should always go and see a physician. So again, risk factors: tobacco use and alcohol use, and aging puts us at risk for a lot of different things. Most people who get oral cancer are older than the age of 40. They work with exposure to polycyclic aromatic hydrocarbons. So what on earth is that? That's just a big mouthful. But basically, they're a group of chemicals that are formed when we burn coal or oil, wood, gas, garbage, or any other organic substances like tobacco or charbroiled meat. So polycyclic aromatic hydrocarbons, PAHs. Periodontal disease, is another risk factor. So when people get periodontal disease, a lot of times they lose their bone, their jaw bone tissue, and that predisposes them to this oral cancer. Other contributors are sun exposure, poor nutrition, poor oral hygiene, and human papillomavirus. Do you know what else? Human papillomavirus 16, do you know what else that predisposes us to? If you don't, that's one of the things that predisposes women to cervical cancer. All right, basal cell carcinoma is the second most common oral cancer after squamous cell carcinoma. Basal cell occurs primarily on the lips. The lesions are asymptomatic, resembles just like a scab. And if you look at the picture that's on there, it has really pearly edges around it. These don't metastasize, but they can be really aggressive, involving the skin on the face. And some people who ignore them end up like much of their skin is affected, and if they don't do anything about it, if they don't get rid of it, it's just going to kind of take over. So one of the risk factors is excess sunlight exposure. The next one is Kaposi sarcoma, and this is a malignant lesion. It's most often associated with full-blown AIDS, people who have human immune deficiency virus, but full-blown AIDS. And these don't only occur in the mouth, but they will occur anywhere on the skin. But these are common on the hard palate in the mouth. And again, that's when they are found in the oral cavity. But they can be found anywhere. So, again, this is another thing out of your book on page 180. Key features of oral cancer: bleeding from the mouth, poor appetite, difficult chewing, difficulty swallowing, poor nutritional status, weight loss, thick or absent saliva. So dentists and healthcare providers can screen patients for oral cancer. So that's one good thing about going to have your teeth checked, is because the dentist will actually screen you. So the lack of that screening puts a patient at risk for not being identified as having oral cancer. So just remember that the biggest risk factors for having oral cancer are tobacco and alcohol use. So if we're doing an assessment of somebody's mouth, this is what we're looking for. Again, we're looking for those lesions, kind of like the thrush. Is a person having discomfort? This is why in clinical I always want you all to make sure you're looking in people's mouths, because a lot of our patients are on not just one IV antibiotic or PO antibiotic, but they're on several. And so that gets rid of the normal flora in our mouth if we take antibiotics. So many times these people will have thrush and it will go unnoticed and untreated. So I always want you to look in their mouths in clinical. As far as their jaw, is their movement of their mouth restricted? The movement of their tongue? Have they had a change in their speech, in their voice, or swallowing? What kind, do they have saliva, or is their mouth really dry? What's the consistency of that saliva? I can tell you if people have radiation therapy, that their saliva gets really stringy and ropey, like it's very drying, and their saliva is real, like you can almost pull it out of their mouth. So again, if you ever see lesions in somebody's mouth, they may need to have a biopsy. So the oral CDX is a diagnostic procedure to brush lesion to determine if the lesion in the mouth is cancerous or precancerous, such as those leukoplakias or erythroplakia. Interventions for oral cancers can always get it excised surgically. One of the patients that I took care of was a smoker and drinker. So it was a long time ago when I worked in ICU when I was a new graduate. But he had half of his mandible removed and half of his tongue removed. So, and then he ended up being on a ventilator. But that he kept his larynx, so therefore he would be able to talk once he got extubated. But it's very disfiguring to have something like that. So we have to really try hard to get people to do A, good oral care, and B, quit smoking. And then the drinking doesn't help either. Alcohol doesn't help either. Another intervention, chemotherapy. Radiation, we'll talk about radiation as well, or a combination of all three of those, surgery, chemo, and radiation can be used. So other non-surgical treatments, and a lot of these are basically, if we're doing radiation or chemo, you always have to have, promote deep breathing. And why do we do that? Because we don't want them getting pneumonia if they are sitting around. Suction available. Why is that? Because if they have those thick secretions, we can get them out. Again, we have to watch their oral airway because of the swelling, or if any of those little chunks of thrush would break off, or whatever. Semi-Fowler's to Fowler's position to promote airway. Fluids, if they don't have any saliva, maybe just dehydrating them will help. Chest physiotherapy, again, can help with the breathing. Steroids can decrease inflammation. Antibiotics, even though they may promote some thrush, sometimes antibiotics can also get rid of, if we have a bacterial infection or something like that in one of our patients, we'll have to use antibiotics. Cool mist, again, will promote breathing. Oral hygiene every 2 hours. Soft bristle toothbrush. You always want to watch the platelet count. And why do you want to watch their platelet count? Because if they have a lack of platelets, they're prone to breathing. Keep their lips moist and avoid, again, alcohol mouthwash. And don't use those. I don't even know if they have lemon glycerin swabs anymore. I think maybe I've seen them recently in one of the hospitals, but they're just swab sticks for the mouth. But I think they might not use those as much anymore. But just remember that when we're talking about the oral cavity and we're treating people for cancers, we always have areas of concern, and one is airway, and another one is digestion, and we're always worried about their oral mucosa and pain. So always protect and maintain the airway. So radiation. External or interstitial implantation. So if you look on page 1081 in your book, and I'm going to get there as well. External radiation, if you've never been around someone who's had external radiation, let's say they do have that, like a tongue lesion. So what they would do is mark an area to direct a beam of radiation, and they mark in ink on the outside, on the skin, like where they're going to hit or where they're going to point that beam, I should say. So they may have treatments every day for weeks at a time. So on page 1081, they talk about implantation of radioactive substances. So it's called interstitial radiation therapy, but the other term for that is brachytherapy. So to either boost the dose or deliver a radiation dose close to the tumor bed. So they implant this, and it can be curative in the early stages, in lesions on the floor of the mouth or on the anterior of the tongue. So this adds a boost of radiation to external radiation. So this is implantable. So when they get this brachytherapy, they stay in the hospital. They can have visitors, but for no more than 30 minutes. They're in a private room, which most rooms are private these days anyway. A tracheostomy may be required. They have an increase in secretions that are thick and rope-like. So it causes a really dry mouth, actually. It may be hard for them to speak or to swallow or to chew. So again, external beam radiation passes through the skin or mucous membrane to the tumor site. Brachytherapy is implantable. So this is all on page 1081 in the reading. Surgical management. Small invasive lesions can be removed under local anesthesia and then sutured. They can use carbon dioxide laser therapy, and carbon dioxide lasers are very precise and they move really thin layers of skin with minimal heat damage to the surrounding tissues. Cryotherapy can be used also, and it's extremely cold. That's what, so one is heat and then the other is extreme cold. And you may know that you can use, for cryotherapy, you can use liquid nitrogen, liquid nitrous oxide, or argon gas. So there's just different things. So surgical management depends on those three factors: the size and location of the tumor. Has it invaded the bone, or has it metastasized to the lymph nodes? So one type of procedure is called a composite resection. So it includes a partial or total glossectomy and partial mandibulectomy. So that is what the gentleman that I was referring to that I took care of in ICU, that is what he had. A composite resection, because he had a partial glossectomy and a partial mandibulectomy. So part of his tongue removed and part of his mandible removed. A commando procedure is a combined neck dissection, a mandibulectomy, and an oropharyngeal resection. If somebody has a tumor that involves the cervical lymph nodes, or the ones in their neck, they have a poor prognosis and end up getting a radical neck resection. So if you ever have someone like this that you're going to be taking care of, you have to reinforce teaching and make sure that you're including the family in that education, because they need to know what the person is going to look like when they come out of surgery. And they're going to need good oral health preoperatively to help decrease post-op inflammation and complications. So post-op restrictions for small local excisions, they'll have a liquid diet and then they'll just advance as tolerated, but there aren't any activity limitations. Now, if somebody has a large surgical resection, like a big tumor, they can expect a temporary trach, oxygen, they need suction equipment at their bedside. They'll have a temporary loss of speech because of the trach. So before surgery ever occurs, you have to establish with the patient and practice with the patient a method that you're going to use to communicate with them. These people are going to be NPO until their suture lines in their mouth are healed. They'll, of course, have IV fluids. They'll be out of bed on the day of surgery or their first day post-op, and they're probably going to have some surgical drains coming out, like JP drains and that sort of thing. If the resection is very extensive, then their speech could be affected because of nerve damage or tongue damage. So they'll probably be seeing physical therapy. So again, how are you going to communicate with that patient once they come back from surgery? You might even get like a dry erase board or some kind, maybe they can use their phone to type messages in, or a computer, or some kind of picture board, or give them pencil and paper, anything to help them. Other things for an extensive resection, again, this is going to affect their airway. So elevate the head of the bed. Constantly monitor for airway obstruction. Keep the incisions clean. Monitor their oral cavity for foul odors, which might indicate that they have an infection. They may need NG feedings or total parenteral nutrition until they can swallow or eat again. Once they begin eating, again, watch them for aspiration. They may need thickened liquids. They may have dysphagia or, just in general, just difficulty swallowing. If part of their tongue has been removed, we use our tongue to swallow, so we use our tongue to talk. So that both of those processes are going to be very difficult for them. If they can have a combination of procedures, again, surgery, chemo, radiation, or all three. If they have radiation and surgery, that again, the radiation can cause a dry mouth because the saliva is decreased. And they can either use saliva substitutes or even their IV fluids, and getting them more hydrated might help. Not saying it will, I'm saying it might. Home care management. Complications from radiation to the head or neck can be acute or delayed. Acute treatment-related mucositis, stomatitis, which we talked about, alterations in taste. Long-term, xerostomia, which is dry mouth, and dental decay. Fatigue is common with both chemo and radiation. Mostly any kind of cancer causes a lot of fatigue. It's common. Self-management. So there's a lot of teaching to be done before a patient is discharged. People can have changes in their taste, like they may end up, maybe they were big meat eaters, but then don't like the taste of beef or pork. That might leave a metallic taste in their mouth after having radiation. So adding seasonings to food, using gravies or sauces to make food more palatable, high protein foods in place of meat, like Boost. They have 30 gram protein Boost. All those type of things can help. Swallowing exercises if the person has dysphagia, thickened liquids, because thin substances are difficult to control during swallowing. Soft foods to prevent injury to the mucous membranes if there is bleeding or if there's stomatitis. Skin reactions from radiation is common. So they need to avoid sun exposure, avoid lotions and powders, clean their face and neck with gentle non-deodorant soaps. If it's a male, use an electric razor to shave instead of an actual blade, and avoid alcohol-based aftershave lotions. Disorders of the salivary glands. Acute sialadenitis is, again, an inflammation of salivary glands. The most common bacterial organisms are Staph aureus, Streptococcus pyogenes, and Strep pneumoniae and E. coli. Just remember that if somebody has radiation or chemo that decreases saliva production, that can lead to acute sialadenitis. There are also salivary gland tumors, but those are pretty rare. They present as localized, slow-growing, firm, painless masses. If they're below the mandible, they may be tender or painful. They may cause facial weakness or paralysis on the affected side, like where the salivary gland tumor is, because there might be facial nerve involvement. So pay attention to assessment of the facial nerve, and if you remember, that's cranial nerve number 7. Hypoglossal nerve involvement causes impaired movement of the tongue. So how do we check for facial nerve damage, or how do we assess the facial nerve? Do you remember that from your physical assessment class? So are people able to wrinkle their eyebrows? Can they raise their eyebrows? Can they squeeze and hold their eyes shut? Can they wrinkle up their nose, pucker their lips, puff out their cheeks, or can they smile, or can they frown? So look for asymmetry when you ask your patient to perform those activities or those motions. Look to make sure that it is symmetrical, like both sides do the same thing. If someone has a removal of a certain salivary gland, the parotid gland, a parotidectomy, patients are at risk for weakness or loss of function of the facial nerve, because the nerve goes right through that particular salivary gland. So I imagine that you didn't know that there was so much. I mean, we didn't even talk about teeth, but there's so much information about the GI tract, and we're just getting started. But to me, it's all very interesting, and I'm hoping to do a few interesting things in here. I know definitely voiceover PowerPoints and that kind of thing are not very exciting, but it can help me help you understand what is on, what you're going to be tested over, and hopefully can help you with NCLEX and different things like that. I want to go back to page 1082. I really like these nursing safety priorities, these action alerts. So read through those in each chapter, because it's good things to know, and make sure that you are looking up the different blue, they're all highlighted blue terminology. So there's a nursing safety priority on page 1082, and there's also one on page 1083. And again, it's basically talking about the one on page 1083 is talking about signs of difficulty swallowing, aspiration, and basically assessing your patient. 1084 is where it says saliva production is greatly reduced as a consequence of radiation. Xerostomia is on page 1085. Again, that's very dry mouth. So there's just lots and lots of new terminology in here. So that takes us through chapter 53. And if you have any questions, please do not hesitate to email me. All right, thanks.